So what I'm going to talk now is, I have nothing to disclose definitely. What are the questions I'm going to address? Because this is a very, still there's a lot of gray areas in ventilation during ECMO. So there are a lot of questions that will be there in your mind about ventilation. Is why we require ventilation when we are getting a gas exchange from the ECMO. Why do we require ventilation? What is the harm if we continue ventilation? What is the harm if we don't continue ventilation? What should be the strategy? Whether one strategy fits all? What will the best strategies in terms of mode of ECMO, P, plateau pressures, driving pressures, FIR2, rate? What are the guidelines that it says? What is the definite thing we should do? What is the definite thing we should not do? Some clinical scenarios and what is the best way out which what we practice, I will tell you in the last. Okay. So why do we ventilate or why to ventilate? It's first to keep the lungs open. Okay? We don't want that lung collapses and there's atelectasis that occurs. Okay. Second, many a times patient has asynchrony breathing and there's some flow issues. So if there are some flow issues, we want to sedate the patient so that the flow issues are not in an ECMO flow. We can get an adequate ECMO flow. Okay. Third is to prevent self-induced lung injury. Silly. Okay. Fourth is as a backup. We always feel that patient is on ventilator, so if something goes wrong with the ventilator, will take care of. So I don't know whether it might be just in our satisfaction, but then that's a mind that is thing. Because many times we are seeing that Tadol is getting deliveries less than 50 ml in an adult patient. So I don't know how much that is going to help, but then that is always in our mind. It's going to be act as a backup. And if at all lung is contributing something, it will be X+1 contribution from the lungs. So that is what we usually hope. Now, what is the disadvantage of ventilation? That all of you know. The disadvantage is your volume trauma, your wire trauma, your atelectotrauma, your barotrauma, diaphragmatic dysfunction, and need of sedation. So these are all disadvantage of ventilation that all of you know. So if we don't ventilate, okay, what will happen? Okay, and if you ventilate, what will happen? If you don't ventilate, if you ventilate the patient, the risk of villi, if you don't ventilate the patient, the risk of villi will decrease, definitely. So we are happy that there is no ventilation, no villi. Okay. But what will happen if you don't ventilate? It increases the risk of silly. Patient can become anxious or patient can remain anxious because of so much of blood and tubing and everything he sees. Your staff attending, if they are not used to it, they become anxious. So that gives the patient to take out the tube, so they become more anxious. Okay. And the increased lung opening time. Always, if the patient is on ventilator, positive pressure will keep the lungs open. If patient is not on ventilator, the lung opening time will definitely increase, and that can delay the lung recovery. Okay. So we have, all of us know the spontaneous breathing advantage is it can preserve the respiratory muscle functions, improve weak-wing mismatch, decrease need of sedation, decrease intrathoracic pressure, better tidal distribution. So these are all advantages of spontaneous breathing, and that's the reason we always feel that we should keep the patient on a spontaneous breathe and off ventilator. Now, what are the best ventilator strategy? Do all there's any standard best ventilator strategy? The answer is no. Okay, because it depends on the mode of which mode. What is the indication of ECMO? What is the mode of ECMO you are using? What is the indication of ECMO? And what patient tolerates? So it can be the best ventilator strategy can be no ventilation at all. Can be a best ventilator strategy in few cases. In some cases, it is the full ventilation that is the best ventilator strategy. Okay. So you always have a controversy. It is whether to go for spontaneous mode versus control mode, whether to go for awake patient or whether to go for proning, whether to extubate the patient or whether to do a tracheostomy and manage the patient with tracheostomy, whether to follow driving pressures or follow plateau pressures. So there are all gray areas where still it basically based on case to case. Okay. So when we started ARDS network, it's a long product strategy. We came out with the target of 6 ml per kg, blood pressure less than 26, high PEEP, FIR2 to maintain saturation 85, and we thought that is the best lung ventilation strategy. But then after some time we found no, this is not still the best ventilator strategy. We thought of the concept of baby lung. And then we said that no, the ultra protective ventilation is best, probably the better than the lung protective strategy. And we come down from tidal of 6 ml to 4 ml, plateau pressures 20 to 25, PEEP of 10, FI to maintain the saturation around 85%, and respiratory rate can be anywhere between 4 to 30. But none of the places where we have specified which mode of ventilator is going to be superior, whether it's just a control mode, just a spontaneous mode, or spontaneous plus pressure control mode, APRV or NAVA. So we are still no clarity about what mode of is going to be better for patient. Now, if you go to the guidelines, the ELSO guidelines initially is used pressure control mode with a decelerating flows, and that guidelines also say that this is just for a safe practice. This is not necessarily a consensus. Okay. Then a European network mechanical ventilation DREVA trial came. In DREVA trial, they use volume assist control mode with the ventilator setting of PEEP of around 10, plateau pressure around 20 to 25. And what are the target volume comes? They accepted it, respirated at 6 to 20, in FI to 30 to 50. And that is what they have done with H1N1 patients on H1N1 ARDS. Okay. Then came the scissor trial. Again, scissor trial used the pressure control mode with the peak inspirated pressure around 20 to 25, PEEP of 10 to 15, respiratory cycle 10 per minutes, and FI to around 30. EOLIA trial, again, that has used the volume control mode, PEEP of more than 10, tadolone to reduce plateau pressures around less than 20, respiratory around 10 to 30, or they have some cases they also use APRV mode. So, and the latest ELSO guidelines says pressure control mode by 25 by 50, I ratio 2:1. PCO2 should be, if PCO2 should be more than 50, then get the CO2 down gradually by 20 to 20 mm per Hg per hour. After 24 to 48 hours, you can make the patients decrease the sedation and try to make the patient on a spontaneous breathing. Okay. Recruitment, till the time there is no significant change in the X-rays or aeration is there, you don't think of recruiting the patients on ECMO during that time. Okay. So these are the ELSO guidelines, what the latest ELSO guidelines, what rather it's a 2017 ELSO guidelines, what it says. Okay. For neonates, again, the peak pressure is 15 to 22, PEEP of around 5 to 8, it's respiratory at 12 to 20, inspiratory time of 0.5 seconds, FI to around 30. Okay. And that is what usually they have recommended. Some centers have used even APRV mode. So after going through all these, what is definite we need to do is to prevent lung injury. That is definite we want to do it. So we want to prevent alveolar strain. We want to prevent atelectotrauma. We want to prevent reabsorption atelectasis, and we want to prevent overdistension. Okay. And that can be done is giving ultra protective ventilation. So you don't bother about the tadolone, even if it is less than 4 ml, that's fine. But see to it the peak pressure does not go above 20 to 25. Okay. Maintain PEEP of around 10 or more than 10. Okay. Decrease ventilator FiO2 and maintain adequate PEEP. And monitor transpulmonary pressures. Okay. So what definitely we are going to do is, we are going to restrict the peak pressures to 20 to 25. PEEP around 10 if there is no barotrauma, and FiO2 around 30. Okay, that is what is definite we need to do. What we are not going to definitely do is, we'll never let the peak pressures to go more than 25, and do not keep the FiO2 more than 60. That is definitely we are not going to do this. So the consensus is rest ventilator setting. Usually most of the centers follow is pressure control mode with 8 to 10 of respiratory rate. Peak pressures of 26, less than 25, 26, PEEP of 12 to 14 for first 48 hours, and then 10, and FiO2 of 21 to 30. Okay. What about ventilation VA ECMO? Ideally speaking, VA ECMO, unless patient goes into pulmonary edema, they doesn't require any ventilations. So no ventilations. If the patient is extubated, patient is already not on ventilator, you don't require to put the patient on ventilator. If patient is on ventilator, you try to get the ventilator out as early as possible. Okay. Again, we follow lungs protective strategy, but that is not very hard and fast because lungs are usually not very bad here. So you might have to consider PEEP, but again, the PEEP has got advantage. Okay, it will decrease the pulmonary edema, but at the same time, it can decrease the venous return. So always you have to go, if the patient is pulmonary edema, you give PEEP. If there's no point in giving much high with the PEEP. FI2 can go up to 50 or 60 also to improve the myocardial oxygenation, because always remember the coronaries and the especially the right side of the brain and right brachiocephalic, they all get blood mainly from the native circulation. So you have to also have a good oxygenation in the native circulation. So VECMO, you can take some liberty, keep the respiratory rate around 12 to 16, inspiratory practice of 24, PEEP of around 6 to 10, and FI2 around 30. So after discussing all these possible things, we'll just discuss few case scenarios. So a 55 years female, elective laparoscopic hysterectomy was done. Patient went into non-cardiogenic pulmonary edema. She was unable to ventilate. She was in type 2 respiratory failure, and she was on high inotropic support. She had an episode of bradycardia. CPR was done. She was resuscitated. Post resuscitation, ejection was dropped down to 40%. Even after stoppage of sedation, patient was unresponsive and pupils dilated, sedated. But it was a witness arrest. This was an X-ray, and this is an ABG, which PCO2 of 122 and PO2 of 32, and pH was 6.9. So we decided to discuss with the family about the possibility of ECMO. She was put on ECMO, on VV ECMO, and immediately after putting on VV ECMO, she improved. We got the CO2 down gradually over 2-3 days or 4 days time, and after 4 days time, patient become fully conscious. He was obeying command. You can see the X-rays out. The X-rays has improved. Okay. And she was obeying command. So this patient then was considered for awake ECMO. She was extubated. The advantage of extubation is going to definitely you are reducing the chance of villi. You can mobilize the patient and give physiotherapy, and you can use BiPAP for maintaining that. So one of the extubation practices we follow is in cardiac ECMO, we usually extubate the patients. In patients with the chronic lung disease, mild to moderate pathology, we usually try to extubate the patient and keep the patient only on ECMO. Chronic lung disease waiting for end stage, again we maintain awake ECMO and mobile ECMO. And those patients with an acute respiratory failure, if they are not tachypneic, if they are maintaining good oxygenation, we always tell them, or they are maintaining good, they are tolerating it, maintaining good respiratory rate, then we usually extubate the patients. Okay. So these are the advantage when you extubate the patient, you can make them feed, okay, mobilize them. Another case scenario is pneumothorax with BPF. So you have X-ray like this, getting bubbling like this. What will be your scenario? So this is an air-leg syndrome where definitely you are going to keep the peak pressures as low as possible, less than 20. Preferred mode is spontaneous mode if you can do it. If you cannot do it, then keep the peak pressures less than 20. Titrate the PEEP. You get the PEEP to 0 and see the bubblings. If bubbling decreases, if there's no bubblings, go up on PEEP of 1. See if there's a bubbling comes up. If there's no bubbling, go up on the PEEP of 2. So you can gradually titrate the PEEP and go up to the PEEP of 6. Okay. Best mode, as I told you, is pressure support modes and differentiation, ventilation if required. Suppose there's a pneumothorax and there's a leak from one side, you can just put a dual lumen tube and ventilate only one lung, or single lung ventilation can be considered. If you have a patient like this with a pulmonary hemorrhage okay, and the lung is filled up with the trachea get filled up with the blood. Okay, this is the X-ray like this. Then you might require to keep the patient on high PEEP. Okay, just for a diffuse pulmonary hemorrhage, the treatment is going to be PEEP. High PEEP is going to help to stop pulmonary hemorrhage. Okay. And many a times we are using APRE mode with PI of 20, P low of 2, T high of 4 to 5, T low as possible 0.6, because CO2 is going to get cleared with the ECMO, so we are not worried about that. So we are just trying to peg the lungs. That is what the strategy follow in case of pulmonary hemorrhage. Okay. This already discussed in North-South syndrome or differential hypoxia. You might go up on higher up on the ventilator settings, and we accept little higher ventilator settings to maintain the good native good situation with the native circulation. Now, what if you try a spontaneous mode and patient becomes tachypneic? So usually, always we prefer to keep the patient on spontaneous mode if patient tolerates. If on spontaneous mode, if the respiratory rate is up to 30 to 34, we accept that respiratory rate. If that is not with the obvious distress or use of accessory muscles, then we accept respiratory rate of around 30. If respiratory rate is going up, what we do is we go up on the sweep gas flow and thereby try to get the CO2 less than 30. The moment the CO2 comes less than 30, the respiratory drive comes down and the patient's breathing settles. So that you can try by increasing the sweep gas and see. What is important is you need to give rest to the lungs, and lung recovery is a priority. So give a chance for the lungs to heal and reopen gently. So what you need to do is just wait and watch. Ultra-protective ventilation strategies should be followed, and recruitment is only when the lungs are ready to recruit. So this is the last slide. What is the best way out our center practices in VA ECMO and VV ECMO? In VA ECMO, at the time of initiation, if there is no ventilation, we don't put the patient on ventilator. If patient is pulmonary edema, we keep the patient on ventilator with the rest ventilator settings in higher PEEP. The moment the edema settles down, we try to extubate the patients. In VV ECMO, with 48 hours, we follow ELSO protocols, get the PEEP down gradually. The patient on PEEP of 16, we don't get it down to 10 immediately. We get it down to 14, and then in 48 hours, we get it down to 10. Okay. And we always try to, the patient lungs are too bad, we always try to prefer to prone the patients. Okay. If there are any evidence of barotrauma or then we get the PEEP pressure less than 20 and titrate the PEEP as mentioned. After initial stabilization, there's no ventilations, and usually we keep the patient extubated. In VA ECMO, if the lung is not an issue. In VV ECMO, we reduce the sedation, we try to keep the patient awake. If patient remains awake, is tolerating well, is cooperative, we put them on spontaneous mode of ventilation. We see how it tolerates ventilator, spontaneous mode of ventilator. If the respiratory rate remains around 30 or less than 30, then we are happy. If it is going high, we try to get the sweep gas up and get the CO2 down and see. If he tolerates and remains stable, we try to extubate the patient. If he does not tolerate, then we put the patient on control mode again and try to validate why the patient did not tolerate weaning. Okay. That is what we do usually. If there are any questions, I'll be happy to answer.